Thanks, Joel. And welcome everyone to this afternoon's session. So my name's Ian. So my role is very simple. It's just to introduce luminaries and then moderate some discussion afterwards. And as Joel mentioned, in this session at least, we won't be taking questions from the floor, but there'll be opportunities for that in the next breakout session. So this plenary session is going to be considering the issues surrounding the legalisation or possible legalisation of medically assisted dying in Australia. Now, few issues generate as much heat and as light as this topic, in part because it is the domain of medicine, among other professionals, in part because the way that we die is closely aligned to the way that we like to live, and also because dying is not simply a medical concern, it's a legal concern, an ethical concern, a philosophical, cultural and spiritual concern. But it's also a deeply intimate process, and you only get one shot at it, right? You only have one death, or at least currently as technology stands, we only get one death. So we care deeply about it. And for these reasons, medically assisted dying has become very much a part of public and professional debate really around the world, and this country has also led to proposals for legislation in South Australia, in Victoria, and soon in New South Wales as well. So this is a vexed and difficult issue. Now, unfortunately, often the discussion about this issue is characterised more by rhetorical statements and by passion rather than by considered judgment or thoughtful reflection. So what we're hoping to do today is to have some respectful discussion about the issues raised by medically assisted dying, really led by three thought leaders, Professor Margaret Somerville, Dr. Rodney, Sanh, and Professor Paul Komisarov. So the session's going to run in this way. Each speaker will have approximately 10 minutes to present their position to you. Close to the end of their time, I'll ring this bell, which I call the bell. This bell apparently has extraordinary magical powers, so it will convince even the good and great to stop talking at that point. I'll then introduce each of the following two speakers, and at the end of that time, we should have about 15 or 20 minutes for some questions, which I will direct to each of the panellists and hopefully encourage discussion amongst the three of them here as well. So hopefully that should all be fairly straightforward. So to introduce our first speaker then, Professor Margaret Somerville is currently Professor of Bioethics at the University of Notre Dame here in Sydney, and she'll be well known to many of you in the audience, partly through her work in the media, but also through her work as a public intellectual in the United States and Canada, and also more recently in Australia. So Margaret was the founding director of the Centre for Medicine, Ethics and Law at McGill University, where she taught from 1978 to 2016. She's received many honours and awards, including the Order of Australia, 8 honorary doctorates, and is a Fellow of the Royal Society of Canada. She recently appeared on the ABC's Q&A program discussing assisted dying, which she strongly opposes. So to get us started, welcome Margaret.
Technology there. Well, thank you for having me to speak to you today. You can see what I think from the title of my presentation. I think that legalising euthanasia is a very bad idea. First, we have to make clear what is not euthanasia. Withholding or withdrawal of treatment, providing it's justified, is not euthanasia. Fully adequate pain management is not euthanasia. In fact, for a healthcare professional to leave a person in serious pain is a breach of fundamental human rights. Physician-assisted suicide is the doctor providing a patient with the means to commit suicide, intending that they could use those means. Euthanasia is a doctor intentionally ending a patient's life. The best example is a lethal injection. There are no relevant moral or ethical distinctions between assisted suicide and euthanasia, as pro-euthanasia people argue. Legalising physician-assisted suicide inevitably leads to legalising euthanasia. And starting with assisted suicide is a deliberate strategy to get doctor-inflicted death, putting it bluntly, killing by doctors, legalised. So that arguments that physician-assisted suicide is acceptable but euthanasia is not are false. In a recent article commenting on new legislation introduced in the United States such as Colorado, California, and it's been for quite a while in Oregon, 7 medical student authors remark, and here's the first thing they say, that some of these new laws and rulings strongly conveys the impression that once a person is eligible for hospice, his or her life may no longer have worth. We reject this proposed shift of the true purpose of medicine, and we reject the pressure to legitimise this shift through the involvement of medical professionals in an act fundamentally antithetical to our core principles. And keep in mind, that's your peers, that's fellow medical students in the US. Doctor-patient trust, the authors assert, is founded upon the notion that doctors will commit to doing their best to heal and care for patients and will not intentionally kill those entrusted to their care. Indeed, the authors call upon doctors to return to the original meaning of euthanasia, which was defined as focusing on improving patients' quality of life and easing the process at the end of life, and never included precipitating the patient's death. So, euthanasia is not medical care. In particular, it's not part of palliative care or just another step on a phrase that's often used to describe the end-of-life treatment in the medical context, a continuum of good end-of-life care. It was under that banner that euthanasia got legalised in Quebec and now in all of Canada. Wrapping euthanasia in a white coat makes euthanasia seem more acceptable to the general public. Surveys show us this, that if we use language of euthanasia and assisted suicide, many more people reject those interventions than if you call it doctor-assisted dying or voluntary-assisted dying or whatever the euphemisms are that you use. Euthanasia is a seismic shift in medicine's ethos and in society's foundational values. It's a revolution, not an evolution. And just keep in mind that I'm using the word here, euthanasia, to include physician-assisted suicide because, as I said, I don't think that they can be morally or ethically distinguished. You are joining a noble profession with 2,500-year history of being guided by the informing principle of care always, cure where possible, never kill. Legalising euthanasia directly breaches that fundamental tenet of medicine. People who are pro-euthanasia claim that euthanasia can be safeguarded with laws and regulations. That is simply not true. There are 2 very recent startling examples, one from the Netherlands, one from Quebec in Canada, where two different doctors who still are very pro-euthanasia have now decided that the abuses that are occurring mean that they very much question what they've done in bringing this in. Vulnerable people, fragile elderly people, those with disabilities are placed at high risk. And even if that were not true, euthanasia devalues them and their lives. It sends a message that they've got lives not worth living. The Australian Law Reform Commission has recently expressed extreme concern that 4 to 14% of all elderly people in Australia are abused. And they refer to early inheritance syndrome, where the people are financially abused by having them sign, usually for a child, to operate on their bank accounts and to use their money. Imagine early inheritance syndrome combined with early death syndrome. Claims that euthanasia will be rarely used as a last resort are not true either. Euthanasia is very quickly normalised. In fact, one example of that, and it's the Quebec issue that I've mentioned previously, there's now calls in Quebec for euthanasia on demand, that the people arguing this are saying they've got a constitutional right to have access to euthanasia. The main doctor who brought in the euthanasia, very eminent and respected doctor, has come out saying, well, if this is what people want, it's not medicine's job to do it. I don't think it's medicine's job to do it, even if you put it in a medical context. Arguments that there will be no logical or practical slippery slopes are likewise false. British moral philosopher Dame Mary Warnock has succinctly explained why. She says, you cannot successfully block a slippery slope except by a fixed and invariable object. In the case of stopping a slippery slope from physician-assisted suicide and euthanasia in medicine, that rule is that we must not intentionally kill patients or help them to kill themselves. Euthanasia is harmful to patients' families, to healthcare professionals, especially doctors. There's now documentation they suffer from post-traumatic stress disorder from carrying it out. It's harmful to society, and it's very harmful to some of our most important values. So the case for euthanasia focuses on an individual and only in the present. That makes a very strong case, but I suggest to you that we must think much more widely than that. The case for euthanasia displays radical individualism, my death affects only me, and presentism, I just look to the present and what I might want at this time. We need also to consider the common good and to consult our collective human memory, our history, look to the past, and our collective imagination, try to look to the future and think, where will this lead, as well as the present, and to take a wise stand on whether to legalise doctor-assisted suicide and euthanasia. We need to consider euthanasia as like a stone being dropped in a pond. It's not enough to just consider the stone. We have to look at the ripples that it sends out, and those ripples will go far into the future. Let's reject, as medical people, let's reject assisted suicide and euthanasia, at least in medicine. And if society still wants it, let's keep it out of medicine. Let's have a group of specially trained technicians, you could call them thanatologists, who would carry this out. It would be enormously dangerous to medicine to bring this under a white coat. Thank you.
I was so looking forward to ringing that bell and I missed out completely. Margaret, thank you for both for staying in time and for introducing us and getting us underway. So our next speaker is Dr. Rodney Sanh. So again, Rodney may be well known to many of you because of his participation in public debate about euthanasia and assisted dying for 2 decades in Australia. So Rodney Sanh became a Fellow of the Royal College of Surgeons in 1964 and practiced as a urologist for more than 40 years. So during this time, his experience with his patients, and particularly with patients suffering at the end of their life, led him to formulate his views about medically assisted dying and also to the public debate around legislating assisted dying for the terminally ill. Now, I think it's fair to say that irrespective of whether one agrees or disagrees with Rodney's utterances in the public space in relation to voluntary assisted dying, what is undeniable is his compassion, his commitment to his patients, and his bravery. Rodney is currently the Vice President of Dying with Dignity Victorian and has just published his second book, Time to Die, in which he considers not only the ordeals experienced at the end of life, but also the suffering endured by those who are not necessarily dying, but incurably suffering. Rodney, welcome.
Well, good afternoon. You might be surprised at the start of your medical career to be discussing whether you might be involved in assisting your patients to die, and if so, how. However, you should reflect that Sir William Osler, a doyen of modern medicine, said in 1900 that it was a doctor's duty to ease death. The truly modern era of medicine commenced after the Second World War, with all manner of life-extending drugs, improved anesthesia and surgery, and invasive medical technologies. We now survive, on average, to 80 years plus and rising. In 1900, average life expectancy was 50 years. Only 5% of people then died of cancer, and people died relatively quickly of acute infections. Alzheimer's disease was first described in 1906, but now 30% of people die with it, and 30% die of cancer, fundamentally because both of these conditions increase with age. This is why you will spend most of your time treating chronic disease and tending to people who are in the last year of their lives who are dying. Your patients will be challenged with the 5 horsemen of the aging apocalypse: blindness, deafness, immobility, incontinence, and loss of cognition, all of which challenge their quality of life. If you are thoughtful and observant, you will quickly realize 6 self-evident medical truths. First, that dying is often accompanied by significant suffering, which can escalate as death approaches. Secondly, that some suffering will only be relieved by death. And thirdly, that doctors have a duty to relieve suffering. These self-evident truths are as old as medicine and unarguable. The last 3 are more modern in context: that palliative care cannot relieve all the pain and suffering associated with dying, that some patients do make persistent and rational requests for assistance in dying, and that doctors have a duty to respect the autonomy of their patients. Careful consideration of these truths will lead you to the conclusion that there are circumstances where there is a necessity to hasten death, especially if it is requested by a patient. Palliative care only developed in the 1960s, and it responded to this change in medicine with new ideas regarding caring for the dying, but retained old ethics based on Christian ideals, a predominant philosophy being that palliative care does not hasten death. Yet such a position is hypocritical, because palliative care does respond to refractory symptoms with terminal sedation, a process of slow sedation to unconsciousness over days without food and fluids, which can only result in a hastened death. Meanwhile, patient assertiveness and a more empathic medical response to suffering are developments of modern medicine, society, and of secular ethics. Medicine has changed rapidly and is still doing so. Old ideas, old ethics are being challenged. Modern medical ethics developed in the late 19th century are based on 4 pillars: autonomy, beneficence or best interests, non-malfeasance or do no harm, and justice. And other concepts such as truth and respect are also considered important. Autonomy is a two-way street, mutual respect by both the doctor and the patient for each other. But if a patient says, "I don't want any more treatment and I want assistance to die," the doctor should respect that, but equally explore that request very, very carefully. Doctors commonly think that they know what is in the best interest of patients, and that may be technically true from a purely medical point of view. But patients may well have a much wider view of their best interests based on their social circumstances and personal values, and it is their view of their best interests which should prevail. Do no harm is often invoked against hastening death, but which is the greater harm, allowing intolerable suffering to continue or relieving that suffering if requested by hastening death? In the 21st century, death is not always seen as an ultimate harm, but sometimes as a good. These 19th century ethics are undergoing questioning and revision in the 21st century. If a patient is making a competent and persistent request for assistance, an expression of their autonomy, which in their view is in their best interests, beneficence, and in their view does them no harm, non-malfeasance, then an empathic doctor must give this serious consideration. Is palliative care the answer to all end-of-life suffering? Well, while palliative care is very efficient in the control of pain, it is not totally effective in this regard. And there is other physical suffering, such as breathlessness, cachexia, nausea and vomiting, incontinence, paralysis, and dependence, which are far more difficult, if not impossible, to relieve. And this does not even begin to consider the huge problem of psychological and existential suffering, which palliative care recognises, which the wonderful founder of palliative care, Dame Cicely Saunders, called the total pain syndrome, but it struggles to affect it. While relief of pain is very important palliative benefit, the relief of psychological and existential suffering is equally important. This suffering is high on the list of reasons why patients request an assisted death. And nothing competes with the provision of control over the end of life of a palliative for this social death. The provision of that control involves an open discussion, the reasons for the need for control, of an exploration and a provision of full information of any alternatives, and of involvement and discussion with family and friends as to the reasons for any decision, and ultimately the provision of medication. Some people reach their time to die which does not coincide with their natural death. It is characterized by a loss of quality of life, a loss of sense of purpose, and a loss of the ability to experience pleasure. There is no logic in continuing a life of intolerable suffering when one could say goodbye and die peacefully. If assisted dying were legal, you could provide your patient with control so that they can choose whether they will have an early death, so they can decide when or where that will happen, who may be present, and they will be able to say goodbye in an atmosphere of calm, security, dignity, and love. Let me finish with a question. What sort of doctor do you want to become? One who will be able to engage in open, truthful dialogue with your patients about their end-of-life concerns, with the ability to assist in the relief of their suffering in accordance with their well-considered request. Or one whose conversations are inhibited by the fear of a punitive law and an inability to meet your patient's reasonable wishes. A doctor who can respond with empathy, or one who is constrained by dogma and hypocrisy. Thank you.
Rodney, thank you again. Okay, our final speaker is Professor Paul Komisarov. So Paul is a physician with a specialist expertise in endocrinology, medical researcher and philosopher at Monash University, where he's Professor of Medicine. Paul's been a member and chair of a number of human research ethics committees and clinical ethics committees continuously for more than 2 decades. He is the author of more than 400 articles in science and ethics, the author of a number of books dealing with moral philosophy, philosophy of medicine and ethics, and is currently chair of the editorial board of the Journal of Bioethical Inquiry and the ethics editor of the Internal Medicine Journal, the Journal of the Royal Australian College of Physicians. Paul.
Thank you, Ian, and thank you for inviting me here today. I've interpreted my task as being a little bit different from the previous 2 speakers. I don't want to put a particular position, but I want to reflect a little bit on the debate itself and to ask the question of whether there's a way forward. And I'm going to put to you 4 sets of propositions, one about the debate itself. Then I'll give some personal declarations about my own views, so you know where I'm coming from. Then I'm going to talk a bit about conditions for reconciliation and then draw a few conclusions. First, about the debate itself, and I think most of us here will be familiar with what I'm about to say. Over many decades, the debate has been characterised by hostility, dogmatism, entrenched, polarised positions, and a lack of communication and dialogue. I think this has been incredibly damaging, but above all, it's been very unproductive for our patients. We've been, the discussion has been characterised by simplistic overstatements that have tended to contribute to confusion about the ethical issues that are involved. Often the debates have been philosophically weak and have obscured the fact that there's a very great deal of complexity. And I'll just give one example here, and that is the use of the word euthanasia, as if there's a problem called euthanasia about which we have to make a decision. There's not one problem of euthanasia, there are multiple problems, and each of them may require a very different kind of approach. Now, just a little bit about my own view, and I have to be clear here. I have sympathy for elements of the views put forward on both sides. I respect Margaret's view about the importance of treasuring the traditions of medicine, and I respect Rodney's deep compassion for his suffering patients. I personally, however, don't feel that legal reform is needed to provide for medically assisted dying in Australia. I believe that the existing law already allows us the sufficient scope for effective and safe responses to the needs of our patients. However, there's significant uncertainty in the law, and for this reason, I think some legal reform is necessary in order to clarify what the actual legal circumstances really are. I'm concerned, as Margaret is, that changes in the law, such as those proposed in Victoria, where I've had a fair bit to do with the process, may actually do more harm than good, in that it may limit or restrict the availability of adequate end-of-life care to those who are most vulnerable and who need our protection most of all. In spite of all of this, we need to accept that we live in a diverse, multicultural, pluralistic society where there are widely differing views. There are many people of good faith on both sides who support for highly valid ethical reasons, as you've just heard, widely differing positions. In addition to that, both sides share a great deal of common ground. Everyone agrees that patients must have an important say in the conditions of their care and must be able to contribute in close consultation with their medical carers to key decisions about the nature and duration of the care that they receive at the end of life. We have to find a way forward. We have to find a way to break the deadlock in order to allow a more productive and finely grained discussion to occur. We can't continue to go round in circles and simply to rehash the same arguments about whether we support or oppose euthanasia. Recognising that both sides share a lot of common values, recognising that both sides have important contentions that we would all agree on, we need to find some sort of process that can accommodate the kind of complexity and ambiguity that we experience in everyday practice. I'm a physician and I work in a hospital, and I recognise one of the reasons I'm inspired by medical practice is precisely because of the complexity and ambiguity of the work that I do, because I'm inspired by the fact that there are no correct black and white answers. We've got to find a way to move forward. The Victorian Parliament has followed an exemplary, democratic and inclusive process, which I think may generate what will turn out to be the least unacceptable, the least worst outcome. This is an important point. We live in a democratic society where we accept that there are multiple views. We have to find ways to be able to tolerate widely differing views. We have a process for generating legal changes. And although I'm not a supporter of the kinds of legislation that's been proposed, I accept that this process has been a good one, that what is likely to be proposed will reflect the views of many people in our community, and that as good citizens in a democratic society, we must accept and support this process and find ways to be able to accommodate the changes in a manner that maximises the benefits for our patients. The details of the law in Victoria are yet to be seen, and it will be important for us to ensure that the legislation will recognise the clinical complexities, that it will provide sufficient safeguards for vulnerable patients, it will provide accountability for the carers, it will provide support for patients and families, but also for the professional carers who are likely to be affected by the results, and also that there will be a formal and rigorous review process so we can assess the implications and consequences of the reforms. So let me just try and draw this to a conclusion. I'm not arguing for one side or another. I'm arguing for a democratic openness, a recognition that there are multiple ways of looking at this problem and that all sides have a grain of truth. In the spirit of the complexity of our work as clinicians, we need to find a way forward that doesn't depend on deciding on a black or white solution. As a community, we need to be able to accommodate multiple viewpoints and perspectives on ethical issues. Sometimes this means that we have to accept compromises that don't satisfy everyone. What's important above all is not whether or not we support position A or position B, and whether our particular ethical or religious perspective is the one that prevails. What's important is that the needs of our patients are most effectively and safely supported and protected. Differing views held within a culturally diverse and pluralistic society must be able to be respected. There have to be sufficient safeguards, as I've argued. There have to be review processes, and there has to be adequate accountability within the system. And then, when we've done this, we need to be able to move forward to a different level of debate, to be able to move away from the caricatured positions of euthanasia or anti-euthanasia, and to think through the specific circumstances in which we make these difficult decisions, so that our ethical discussions can be directed very deliberately and practically to the clinical issues that we grapple with in daily life. Thank you.
Okay, thank you again, Paul, for your timing. So So we have about 15 minutes for some questions, which I'll put to. I've left my glasses, so you're all three hazy shapes on a lounge. But Paul, I might start with the point that you left us with, which strikes me as quite challenging, because you're suggesting in a way that this debate may, to some extent, or not necessarily the debate, but legislative reform or major legislative reform may be unnecessary. So if I could sort of summarise your position. So you suggest that most of the time, arguably, we can actually address suffering in our patients. And that's, I think, consistent with most literature, that most of the time we're quite good at that. Most of the time we can recognise where the ends of medicine are not being served by continuing treatment. We can recognise where treatment is futile and we can stop treatment. And then the third is, and perhaps more contentiously, is that we can act currently as clinicians in ways that hastens people's death, that brings them closer to that point of death, whether it's through taking them off a ventilator or using narcotics or sedation in particular ways that brings forward their deaths. So your sort of premise therefore is that actually that's functioning well, and with a good palliative care system, that this may be all that's necessary. So, Rodney, can I ask you then, do you accept Paul's suggestion that we actually don't really need to have the kind of legislative reform that would enable physician-assisted dying or medically assisted dying as is being discussed, and whether at the current time, with some sort of clarifications, things are actually okay as they are?
No, I don't agree with that. It's a premise that people say, well, everything's all right for most people. That most people will have a satisfactory death, that most people will not need assistance. But that's a point of view that leaves a percentage of people to suffer. And the analysis of figures from people in palliative care is this is anything from 5% and upwards. That's a significant number of the people who die in Australia every year, who die with suffering that they would wish to bring to a speedier conclusion. They don't want to die. These people want to be relieved of their suffering. And at the present time, people in the medical profession, faced with the problem of a person who has severe suffering, which cannot be effectively relieved, is in a very, very difficult and embarrassing position. From an empathetic and compassionate point of view, they may desperately want to help that person, but they are deeply constrained by the law. What options do they have? Well, eventually, if the suffering reaches refractory state, they can be given what's called terminal sedation and put slowly to sleep by titration, that is the term that is used, drip by drip, gradually increasing the amount of medication until that person becomes unconscious. They're not given food and fluids, and they remain unconscious until they die. That's a process which may take anything from 2 to 5 days, with their family sitting patiently waiting for death. I certainly don't want to die that way. What alternatives are there? They can voluntarily refuse food and fluid. They've got a legal right to do that. Big deal. Who effectively wants to be forced to take that option? Or they can legitimately refuse medical treatment. But not everybody has medical treatment to refuse. If I'm a high quadriplegic, not dependent on any treatment, my quality of life may be something that is intolerable to me. I've got no treatment to refuse. I must go on and on, for years possibly, with intolerable suffering. The issue is essentially one of suffering which we as doctors cannot adequately relieve as far as our patients are concerned. And are we just to say, bad luck, mate, you'll have to lump it? I don't think we should.
All right. Margaret, can I give you Rodney's challenge then, which is to say, well, look, what right do doctors have where somebody is suffering, intractably suffering, let's say, in this situation? They've had access to good palliative care, and they've made a considered and very clearly reasoned and supported request for assistance with dying. What right do we have as doctors to refuse that request? And if we refuse it, what can we do?
Well, first of all, you've got to work out why they're making that request. And in actual fact, pain, for instance, comes around number 14 on the list of reasons why people want euthanasia. And the top reasons are loss of control over what happens to them, loss of independence, feeling that they've lost their dignity. So one of the questions we have to ask is it the role of medicine to relieve all suffering? Because mainly the causes of asking for euthanasia are existential suffering, not physical suffering. The physical suffering can on the whole be relieved. And I think we have to say it isn't the role of medicine to relieve all suffering, and one of the reasons we're in this difficult situation is people don't have access to other ways in which that suffering can be relieved. There's a very interesting new book by Dr. Harvey Max Chochinov, who's a North American psychiatrist who specialises in the care of terminally ill people. And they've devised a psychotherapeutic intervention where even people who have asked for euthanasia change their minds after this intervention. And I think it can be summed up in the words of Viktor Frankl, who was in a concentration camp and wrote the book about finding meaning in life. And he said that when people have a why to live, then they can find a how to live. And actually, Rodney, you brought up that people said, you said they've had lost any purpose in life. And what Harvey's work shows is if you can give them back some purpose, no matter how short term, they won't necessarily want euthanasia. Now, I just want to say one thing about Paul's comment. You can't be a little bit for and a little bit against euthanasia. If you're not against it, you are for it in some form. And you can't be neutral on this. It just isn't possible. And you've got to decide what the law should do. At the moment, it's totally prohibited. And what Rodney wants is that there will be exceptions made to that. That's the question we have to ask ourselves and decide, will we do that or not?
Yeah. So in fact, Paul, can I put to you then to start, and I'd be interested in, Rodney and Margaret, your thoughts as well, Margaret's mentioned during her presentation that she felt that palliative care and euthanasia or medically assisted dying, those kinds of structures of care can't coexist, that logically they can't coexist. And Margaret, that's a fair summation, is that it's a striking part of the discussion within Victoria and just starting in New South Wales that there isn't a discussion about truncating palliative care, so the expectation is that both can be supported. So my question to you to start with, Paul, is that do you think it is possible that actually you can run effective systems of palliative care and also legislative reform that enable doctors to assist patients to die at the same time? So in other words, does it not diminish palliative care, or does it enable it in some ways as well?
I don't think it's just about palliative care at all, and I think it's important for us not to confuse palliative care with end-of-life, or conflate palliative care with end-of-life treatment in general. It's our job as doctors to treat our patients, and whether or not we're palliative care physicians or general physicians or specialists in some other area or paediatricians, we will be dealing with patients who die and who suffer. So the domain of treating end of life or treating suffering is not the field of a particular area of expertise called palliative care. It's the concern of all of us. Let me just make a couple of points about what Rodney and Margaret just said. First of all, I made the point that there's not one problem of euthanasia. It's easy for the word rolls off the tongue. But euthanasia has multiple meanings, and we've heard many of them already. The question of someone in the terminal stages of their illness, in clear consciousness, suffering unrelievable pain, is the subject of all the proposed legislation in Australia. There's none of the other circumstances are being considered, and that's really, I think, what we need to be focusing on at the moment. The problem of someone with a chronic illness who's not in pain and whose death is not imminent is quite different. The problem of someone with dementia the problem of someone with severe psychiatric illness, or of children and so on. These are quite different problems. They raise very different ethical questions, and they can't all be rolled into one. I made the point that what attracts me and many other people to medicine is the fact that it's not just about black and white solutions. We've got to deal with ambiguity, and we've got to think of the specific circumstances of every individual patient in each case, and they're always different. There's no single generic question of euthanasia. And I'll add to that about the way you posed the question originally, Ian, and that is about the category of suffering. There is no single category of suffering. Medicine is about treating suffering. Every doctor throughout history has to deal with different modalities of suffering, different ways in which people experience their lives in difficult, uncomfortable, sometimes painful ways. Suffering is not just about pain, as Margaret said. Suffering has multiple dimensions, but that's our job. That's why we're here. So again, it's too easy to say unrelievable suffering, euthanasia, kill the patient. That's not how we deal. We need more complexity. Now, just to get back finally to Rodney's point, there is no such thing as circumstances where we have nothing more to offer as doctors. If that were the case, we need to go on and do something else. The toolbox is never empty. We always have resources that are available to us. And when I said that I don't believe that the law needs to be changed, what I meant was that it is my understanding that we can use whatever is needed and is available to us to be able to address the problems of our patients, the problem of suffering. And if in some circumstances that involves the administration of a medicine that hastens death, then that's perfectly acceptable under Australian and English law, and it's perfectly acceptable ethically. I don't think we need formal legislative processes in order to do so. However, as I said, there is uncertainty, and therefore there's a need for some clarification. But essentially, our toolbox is never empty.
All right, Margaret, you wanted to come in there?
Paul, you can't administer something intending that you will shorten the person's life. That is not acceptable under our law or under any law that has not authorised euthanasia. What you can do is if some treatment is needed, for example, to treat extreme pain, and there is a risk that could shorten the person's life, although that should be rare if you know what you're doing, then yes, you can do that because your primary intention is to relieve the pain and you don't have an intention to shorten life. But you cannot relieve suffering by intending to shorten life.
So can I respond quickly, Ian? So this is the point on which Margaret and I are completely in agreement. I don't believe that one can legally or ethically, under the present circumstances, intend to end someone's life. But as a doctor, I can never imagine why I would ever want to do so. It is never my intention to kill my patient. Life is never the disease and death is never the cure. If someone is suffering, my target is not their life, but their suffering. And I will do whatever I need to do to alleviate that suffering appropriately. There is never a need to intend to kill someone.
So this is an important both empirical point and philosophical point, as Margaret mentions. Rodney, I mean, Paul's made a very categorical statement there, that death is not a solution to a problem, the problem being life, but I think we can read, illness, disease, infirmity, what have you, into life as well. So do you think that Paul is right there, that there are not times when a doctor acts not simply to end somebody's life and to intentionally end it, but they act in a way where they want somebody's suffering to end, and they act with two intentions. They act with the intention to end that suffering, but they are also acting in a way that they know and they want the person's life to end. Do you think there are times when doctors do act in that way, and what do you think about that type of action?
I think it's important here to recognise that the law that is being proposed in Victoria and a similar model, which will subsequently be debated in New South Wales, categorises assistance as being one of self-administration by the individual with the suffering, not the delivery of a lethal injection, except in the one circumstance that the person is unable to self-administer. That is very rare, but to leave those people discriminated against would be unacceptable. And so if I'm allowed to self-administer, but Margot can't, then she should not be discriminated against if she still wishes her suffering to be relieved. There's a real problem with the question of intention, because it's really, when we're talking about it towards the end of life, it's a legal concept. The law determines if somebody's intention is to do something. But intention is far more opaque than that. I'm a great follower of Timothy Quill, who's a fabulous American doctor, palliative care doctor, and he writes about the duplicity, or not the duplicity, the multiplicity of intentions that can be operating in circumstances. The Dutch have been pilloried because they have used lethal injection as a way of assisting people at the end of their life with suffering, and it's argued that that's their intention is to kill. Well, if you're delivering a lethal injection, certainly what you're doing is killing that person. But I would argue that if you could get to the truth of the matter, their intention is to relieve suffering. And it is done by a lethal injection, yes, but their primary intention is the relief of suffering. If I'm providing medication for a person to take orally, if they have come to the conclusion that their life is full of suffering and they want it to end, then I give them the medication with the intention of relieving their suffering. It is down to their intention as to whether they take it and whether they end their life. And the evidence from Oregon is that at least 30% of people who are given medication don't take it. Why? Because the provision of that medication has alleviated the psychological and existential suffering, which is huge. It alleviates that, and they find they can go on to a natural death. If I can recommend one thing for you young medical students to read, it is a paper by Eric Cassell called Diagnosing Suffering, and it's printed in 1999 in the Annals of Internal Medicine. And you will never read anything that is more important in giving you an understanding of suffering in the medical context than that article. And I recommend you all read it.
All right. Thank you. And the other papers that Rodney refers to are some papers by Timothy Quill that were published in the New England Journal of Medicine, and do really beautifully describe the philosophical and the clinical challenges of dealing with somebody at the end of life and personal reflections. Margaret, you wanted to make a comment quickly before we finish up.
Rodney, with respect, what you're doing is confusing intention and motive. And what the law looks to is, what is your intention? Your intention is to relieve the suffering by killing the person. Your motive is to relieve the suffering. And so
I'm not killing anybody when I give them medication. They will make that decision. They have the control.
You're resisting them to kill themselves.
I have given them the opportunity, yes. But recently I was brought before the Victorian Civil Administration Tribunal by an action of the Medical Board. And the Victorian Civil Administration Tribunal accepted the fact that the provision of medication giving a patient control was a palliative action, and that the action that I was taking was of no harm to the person and persons to whom I have given that medication. The question of intention, I would suggest to you as a legal concept, is a load of garbage. How do I know what's in your mind at the present moment, Ian? What do I know is your intention here? To direct this debate in one direction or another? No. Nobody can say that. So intention is a very, very poor indicator of what a doctor is actually wanting to do.
All right. Now, I'm actually going to draw to a conclusion because we are quite a bit over time. But thank you all, and there will be other opportunities to address questions to Margaret, Rodney and Paul. I think what we would all encourage you to do is to read, to talk, to think to look at the experiences of patients in your own clinical contacts and get involved in this debate. I think clearly, Margaret, you will be sort of advocating on behalf of no change to enable legislation of euthanasia. Rodney, on behalf of euthanasia legislation in Victoria. And Paul, I think you'd be happy to go along with whatever's decided as long as the process is democratic and respectful. Is that a fair? At least that'll do for now, at least, anyway. And Rodney, I'm very glad that you can't see into my mind at any point. That's not a good place. So thank you, everyone, and we hope to see some of you in the next breakout session.